Meenakshi, are you ready? Meenakshi?
Yes, sir, I'm here.
Okay. I'll count 5 and start. Okay, 5, 4, 3, 2, 1. Good evening, dear brothers and sisters. I am very happy to connect with you through our masterclass webinar series. This is the 10th webinar, which is going to be one of the important and interesting topics which we are going to discuss. Along with World Lung Foundation, everybody knows what is World Lung Foundation now, South Asia. A major aim and objectives include public health ranging from cardiovascular disease, control and prevention to road safety, environmental health, to civil registration and vital statistics. All public health related activities and the scope of the work cover comprehensive public health services. Most of you know what is the whole Medical Academy of India. I am very happy and thankful to all those people who registered and enjoyed our scientific feast the last Saturday, Sunday. I will be sending you the certificates once everything is in order. Medical Council accreditation also will be sent to you. We will send you the communication, the procedure, how you should get it. You know the objectives of the webinar, to promote standardized care for hypertension. It is evidence-based, aligned with international best practices. The focus of the virtual workshop would be to promote standardized care of hypertension based on recent WHO guidelines, promote opportunity screening of all patients over age of 18, to reduce physicians' inertia to start and continue treatment of hypertension, importance of medication titration, adherence, follow-up of hypertensive patients. These are the webinars we conducted, and you can see this is the last webinar, Women and Hypertension. Now, many of you are accustomed to our Kahoot. If you are new, please download Kahoot app and then be ready. We will give you the game pin. And as usual, those who get top 3 podium winners will get a BP monitor from us. So, Women and Hypertension. The speaker is Dr. Geeta. I am the moderator, and Dr. Meenakshi is a panelist. Geeta, she did both UG and PG from Coimbatore Medical College, MD in General Medicine from 96 to 99, gold medalist in gastroenterology during post-graduation in General Medicine. At present, working as a professor of medicine, Coimbatore Medical College. Received FICP award during January 2016, Epicon. She's a great teacher and good communicator, good academician. In fact, for this program, Women and Hypertension, she was preparing for the last 3-4 days like an exam going student. In fact, I gave two inputs, and for all my inputs, she was getting reference and completely herself prepared everything, and you are going to have a real good scientific feast from Geeta. Now, of course, Madam Meenakshi there. She is the additional professor and head of the Department of Medicine, All India Institute of Medical Sciences, Rishikesh. A teaching and research experience of around 18 years. Supervised more than 50 postgraduate theses. Involved in conducting various research projects at national and international institutional level. Present papers and delivered guest lecture at national level, over 100 national and international publications. Life member of Indian Association of Clinical Medicine, Association of Physicians of India, Geriatric Society of India, and Indian Association of Geriatrics. Fellow of American College of Physicians and Association of Clinical Medicine. Again, she is one of the brilliant teachers. She trains students in such a way that most of our students, whenever they appear for any competition exam, they will score gold medal. And she's also running hospitalist medicine course in her AIMS under her leadership. I think this is the second or third institution where we have hospital sports. She is also planning to conduct hypertension clinics in her hospital. Okay. Yesterday, somebody called me and asked me, sir, why you want to do women and hypertension? Is there any difference about hypertension with women? Yes, I told him. You remember 5I: under awareness, under diagnosed, under treated, under supported, and under researched. Most of the research trials, they don't include women. At least now, for the last few years, they're including women in the trials. And very late diagnosis. If suppose somebody has got hypertension in women, we don't get, we diagnose very late. And you advise the women on lifestyle modification, especially how to reduce weight and all that, they don't follow. And when they are smoking or take alcohol or loss of sleep, they have more problems than men. So high risk for everything. And even side effects of some of the drugs are more. And salt sensitivity. And low HDL is more risky in women. I'm sure Geeta is going to discuss all these things. Okay, you may wonder, I put this picture. This is not my idea or my, this Binky model is by the professor Naret Wengner. She's the professor of medicine, Division of Cardiology, University School of Medicine. She always worked her life and dedicated her life for women's health. What she said was, I tell women to be bold. Be bold in taking care of your heart health. Check with your primary care provider. Know your risk. Get heart check. Why I saw this? Because she said women are always informed about breast cancer, cervical cancer. So they are not talked about heart checkup or hypertension. She said, combining all cancers put together, the mortality is much, much more in hypertension or heart disease than the cancers. So that's why don't have the this approach. You have to look at the heart and hypertension. And she said, transforming cardiovascular problems for women. This is Dr. Nanet Wengner, who has done a lot of work on women. She's now about 92 years old. You know, hypertension prevalence is lower in women from adolescence until menopause or fifth decade of life, following which the prevalence of hypertension increases deeply in women. This is what we thought. But a recent study demonstrated that women actually have a steeper increase in BP as early as third decade that continues throughout the life. Not only that, 10 millimeter increase in systolic blood pressure, women experience 25% increase in CVD risk, while the men risk is only 15%. So blood pressure really affects the women, especially in postmenopausal area, time, more than men. What is opportunity screening? Because as a public health man, I want to make a message, and being the person from the beginning, talking about opportunity screening. When, 2 months back, one of the gentlemen came to me. I asked him, how is his wife? He said, sorry, my wife is no more. And he is coming regularly for checkup for his ischemic heart disease. The problem is the women accompany the men, husbands, but they don't undergo any checkup. So what I mean is opportunity screening. When woman accompanies man for his checkup, check her blood pressure also. So this message you should follow. Any doctor, any physician, anybody who's seeing the men for cardiovascular problem, please ask him to bring his wife for cardiac checkup. Hypertension in young adult, these are the main headings you must think about women and hypertension. We don't think women hypertension means only one phase. Biologically, they have so many lifestyle changes or life cycle. What is hypertension in young adult women? Hypertension in pregnancy is a big chapter. Then ART, assistive reproductive technologies and hypertension. Most of ART, they have a lot of problems of hypertension. Hypertension and menopause. Hypertension in elderly women is again another big subject, and less representation of women in hypertension clinical trials. So these are the headings by which you should discuss about or know about hypertension in women. Geeta has prepared extremely good, and you will be listening to her in the all headings. Communities, countries, and ultimately the world are only as strong as the health of their women. This is Obama's talk. So, ladies and gentlemen, I am very happy to hand over the podium to Geeta for his talk on women and hypertension. Over to you, Geeta. I will now stop sharing. You can start sharing your slides. And I also welcome Dr. Sadanand Sethi, a wonderful cardiologist from Mumbai, and Dr. Prabhakar, a young and dynamic cardiologist from Chennai. You know, this two are additional bonus today. When I was talking to Sadanand and Prabhakar about women and hypertension, they voluntarily said, we also would like to take part in the discussion. So we have got good two cardiologists apart from Geeta and Meenakshi there. You are going to have plenty of information, new information on women and hypertension. In fact, Sadanand Sethi also had given me 2 slides. He said after Geeta's talk, after the Kahoot, he will give the presentation. And Prabhakar is a very inquisitive man. Whenever he asks any question, questions are such that nobody can answer. So I'm there. I'm happy that Prabhakar is there to ask questions so that it will kindle our interest.
Sir, I don't know whether
future
it's good or bad.
Anyway, he will ask always. And Sagram is our own person. So he is also there. So with the introduction, so I always take some time to do all that because so that there'll be crowd of 150 or 180 so that the speaker will speak for 200 people. So when I started, it was 100. Now it's become 150. Now over to Geeta for her presentation. Geeta, you are the flow is like this. You will present. There'll be Kahoot. Then Sadanand Sethi will focus only 2 slides, and then we'll have discussion. Okay. Thank you so much. Now over to you, Geeta.
Thank you, sir. Thank you very much. Shall I share my screen?
Yeah, you can share the screen. Yeah. Allow them to share, enable sharing. Sorry, but
Just a minute.
Geeta, do you need any support? As Geeta is preparing, WHI, that Women Health Initiative, is a big trial where they talk more about women and women's health. So normally in India, we don't give, not we, women don't take their health properly. They always worry about their family, sons, husbands. So they ignore their health. That is why women and hypertension is very important. And then the mortality in US, they say 38% put together all the malignancy, everything. So women should be healthy, not for her, for the sake of the family and the community. When she is strong, then only she can take care of the family and the community. Geeta, any problem, Geeta? Megha, you have her slides, no? Why don't you present the slides? Megha?
Yes, sir. Yes, sir. I have her slides.
Okay, you can present. Geeta can go ahead. Geeta, is it okay?
I will just try it once. Just once.
The other thing, Dr. Muruganathan, what
Yes.
you showed, Nanette Wenger was with us,
Yeah.
2 years back.
Yeah, that's why I showed the slide purposely.
Yeah. AOC, our academic cardiology in Mumbai 2 years back, she came, she was with us 2 days. I mean, outstanding lady, yeah. And she's, because the entire 2 days was on women and the heart, that way. So that was Dr. Pelajani, our academy,
Yeah, that is, see, she only said, don't have bikini approach for women.
Yeah.
That is why I showed that picture. Because everybody will, be happy to know that bikini picture. They'll remember, okay, that's what Madam said. That you don't have the approach.
She also highlighted about this 4th trimester, we talk about now, normally we don't talk about a 4th trimester, so that part was a little attractive at that time, because first time I came to know 4th trimester at that time,
Right.
So now we are giving importance to that also,
And you can apply for an award in her name. Somebody who's done a lot of work on women's health. Meenakshi, you can write to, you can send her your article and we'll support and we'll get that award. It's a gold medal award. The name of her, Nanette Wegner. Geeta, are you ready, Geeta? Don't worry, we'll project the slides. Megha, you can project the slides. Geeta, you can use that. Yes, Megha.
She has to unmute herself, sir. She's both muted and videos off.
Yeah. Geeta?
I think I have a problem. I request Megha to
Don't
share.
worry. We'll project the slides.
Yeah.
Sir, it's visible?
Yeah.
Yes,
Make it
yeah.
make it slide. Yeah.
Yeah.
Okay, Geeta,
So,
you can go ahead.
yes, sir.
Yes.
Yes, I'm very sorry for that small delay. I could not get to my folder.
No, actually, Geeta, you would have seen my first slide. Women are under supported, not in my case. We always support women. That is why we have 2 women to support your slides also. Okay, go ahead.
Sir.
Yeah.
Thank you
Next
very
slide.
much, sir. I like your introduction very much, and I actually enjoyed your introduction where you stated that I was preparing like a schoolgirl, and it is indeed true. And I usually enjoy doing that to myself and for the better academic program, betterness of the academic program. So thank you very much, sir. So coming to this topic, as already introduced, it's a wonderful topic. I say wonderful because as I was talking to Dr. Muruganathan a few days back, one thing I really appreciate is it's not about always getting updated and helping people across the length and breadth of the country to get updated. It is more to do with issues regarding health that really impacts a large section of people. It's not confined to certain specific areas, but these are areas which really impact the entire health of a nation. That is one thing which I always think about. It impacts the health, a woman's health. In fact, it is stated that where women are honored, gods are pleased. So apart from the literary status, the education, the health, and the support system. And I think hypertension is one among the simplest of healthcare problems which can be recognized and women can be reached out to, treated, diagnosed, and quality of life can be improved. Despite the various technological advancements, basics always remain basics. And this is one statement which I always tell to my students as well. Next slide, please. So the next slide.
Megha, next slide.
Megha, next slide.
Megha, next slide.
So this is just a pictorial representation to say that a woman suddenly finds herself to be hypertensive. And it is indeed a rude shock. But then, in due course, the impact fails to continue in the same way. Especially, I have seen certain things during the course of my practice. A woman becomes very responsive and also she is always ready to listen to the physician who treats her during her pregnancy. After the pregnancy, in general, the concerned individual, the family members, the social support system somehow does not take the same kind of interest. So throughout the course of her life, there are many reasons why exactly a woman can become a hypertensive. And of course, as we all know, hormones have a huge impact on her body. Next slide, please. Estrogen is indeed a multifaceted hormone. And why I would like to stress upon estrogen at this point of time is because it's a known fact that women have a biological superiority. Left alone, nature would prefer to have her women rather than the men. That is for the propagation of her species. And estrogen is one such wonderful hormone, which is a youthful hormone. And to what extent estrogen can impact the various aspects of physical health and thereby the life of a woman. So it acts from the endothelium to the brain. Estrogen causes endothelial vasodilatation. It enhances the nitric oxide synthesis. It has a sympathetic depressor effect. It inhibits the sympathetic activity. It enhances the parasympathetic effect. In fact, we have all heard about heart rate variability, which is nothing but the sinus arrhythmia. And during my physiology days, I remember having been taught that sinus arrhythmia is something which keeps you healthy. It means that your heart is healthy. We start losing on this interesting phenomenon of heart rate variability as we grow older. And as a woman reaches menopause, with the impact of estrogen getting down, this heart rate variability is lost. So this is again a wonderful effect of estrogen. The renin-angiotensin system is again a pivotal system as far as the pathophysiology of hypertension is concerned. It is again a system which has got a huge impact on so many aspects of electrolyte, fluid balance, and hypertension, blood volume, vasoconstriction, etc. And estrogen has a big role by reducing the plasma renin concentration and increasing angiotensinogen. All these activities in turn reduce sympathetic activity. The reactive oxygen species is reduced by estrogen and thereby enhances the antioxidant effect. So we can go on talking about estrogen. And in fact, estrogen is also supposed to have an impact on the hypothalamus, the hippocampus, because we all know that hippocampus is associated with memory. And it is even stated that as women start losing estrogen, there is a cognitive decline, there are mood changes. So all these do make us understand that endogenous, and it's even more interesting that all these things happen only with the endogenous estrogen. On the contrary, when exogenous estrogen is given in the form of oral contraceptive pills, we find that women go in for a hypertension. So it's such an interesting phenomenon. And this singular phenomenon itself can speak volumes about how it impacts BP and in future, the hypertensive status of a woman. Next slide. So anyway, this is just to say the white pictures are to demonstrate the youthfulness. And as a woman ages, you find that the youthfulness declines and estrogen has a huge impact. Next slide, please. So before I go further, I would not be able to do justice if I just do not mention about this renin-angiotensin-aldosterone system. It is independent by itself, but now just to make it more clear, I just wanted to mention about the impact of one on the other. The renin-angiotensin-aldosterone system has a big role in the regulation of blood pressure, volume homeostasis, electrolyte homeostasis, sodium, potassium through aldosterone production, renal blood flow. As we all know, angiotensin 2 causes vasoconstriction. It is the most potent vasoconstrictor known. It has a greater impact on the efferent arteriole of the glomerulus. It impacts the glomerular filtration rate. In fact, in the fetus, the renin-angiotensin system has a role in the nephrogenesis. And of course, it has a pivotal role in the pathogenesis and progression of hypertension and renal damage as well. So estrogen, how does it act? As already mentioned, estrogen reduces the plasma renin concentration And hence premenopausal women have a higher circulating level of angiotensinogen. And once the estrogen levels reduce, because of renin being at a higher concentration, angiotensin 2 levels are higher, and hence that explains to a major extent why post-menopausally women go for hypertension. Next slide. So, as already Dr. Muruganathan has stated, women go through hypertension in different formats, in different aspects during the various stages of life. Of course, my previous slides were predominantly confined to the role of the hormonal system. But hormones, yes, they do have a huge impact when it comes to women and to the quality of their life and to the future status of hypertension, cardiovascular diseases, etc. But it does not stop with that, because we are living in a world, and women in particular have an exposure to various kinds of inputs. The quality of life has changed, the nature of job, the lifestyle, all these have a big impact on women. And I must be very particular in saying that it is particularly more so in teenage and young adult women. We do see obesity as one of the prime problems these days. And whether it is associated or not, PCOS is again a huge endocrine problem, may or may not be associated with obesity. And the biggest problem comes because women have now gone into a state of sedentary behavior dictated by the needs of today's academics, the needs of the various other kinds of stresses and that actually happens around them. And we have to always look into the possibility of family history, obstructive sleep apnea. These are all certain things which are unrecognized. We don't usually ask when women come with hypertension. That is one thing that I have observed whenever we have a huge volume of outpatients. Any patient coming with hypertension is generally branded as an essential hypertension or a primary hypertension. Or in general, the treatment, the diagnosis is just given as a systemic hypertension. And I think this mindset has to change. Already there was a phrase which was put by Dr. Muruganathan, which stated, there is a physician inertia. And this inertia, actually, we just take the high BP for granted. So my simple suggestion would be to observe a patient. And here our focus should be on the women. Observe them and get the appropriate history, because that may make a huge difference in the quality of their life. So I will just recount one very interesting anecdote. This happened around 15 to 20 years back when I was sitting in the OP, and a young girl, she was around 15 years, who came to us, and we found that she had a history of headache, severe headache. And I asked my house surgeon to see her blood pressure, and we were shocked to note that it was around 200 by 100 or so. And it was repeated on the opposite limb. Again, it was such a high blood pressure. Then I asked her to examine the lower limbs. We found that the pulses were absent and the blood pressure could not be recorded. We had a strong suspicion of coarctation of aorta, and we referred the patient to a higher center because we work in the government setup. And finally, it turned out to be coarctation of aorta, and the appropriate management was done, and she came back to thank us. So this is potentially an incident which tells us that appropriate identification can make a huge impact on the life of an individual. In fact, it is something between life and death. So this has definitely prevented her from the possibility of a cerebrovascular or a cardiovascular accident. So the simplest things that I usually teach, and I would also like to tell here, is listen, observe, and always talk to the patient. I have quite a number of youngsters, young girls, who literally tell me that there is no concept of play hours in the school, and there is nobody in the neighborhood with whom they play. I think nature has designed in such a way that all these little aspects of growing up are essentially to lead a healthy life. But somehow we have gone far away from that. And that does impact the life, the quality of life in the form of hypertension from young age itself. Added to the fact that teenagers also have a heavy use of oral contraceptive pills, and given the fact that there are certain causes of secondary hypertension which are exclusive for girls or for young women in the form of renal artery obstruction, and there can also be endocrinal causes. Endocrinal causes should never be forgotten, especially thyroid disorders and also primary hyperaldosteronism. All these are things which can be picked up by proper observation, a good history, and of course, certain things which are exclusive to women include Turner's syndrome, Takayasu's arthritis. Sitting in the OP and just putting the hand on the pulses will go a long way in finding out the cause of the high BP. SLE, rheumatological conditions, all these are exclusive in the feminine population. So I would repeat, and there's nothing wrong in repeating because it's not always about the estrogens or the RAS, but it is to remember that a proper history, a proper communication, explaining the impact of sedentary behavior, listening to the family history, observation of the pulses, examining the BP in all the four limbs where and when necessary. All these are absolutely essential when it comes to identifying the cause of hypertension in the young. And secondary hypertension is to be also considered anytime women less than 40 years come to us with high BP, and when the BP at the time of presentation is very high, that is grade 3 hypertension, and postpartum women who continue to remain hypertensive 3 months after delivery. So these are all the other situations where we also think of secondary hypertension. And of course, the exclusive areas include hypertension of pregnancy and menopausal and postmenopausal hypertension. Next slide, please. So I will deal with pregnancy hypertension later. And just to give a brief about this menopause and hypertension, menopause is one scenario where there is a precipitous rise in blood pressure. Dr. Muruganathan just gave an information that women start developing hypertension from the age of 30 years. But menopause is a period where there is a precipitous change, a rise in blood pressure. And it is equally interesting to note that there is also greater resistance in the treatment of hypertension, the hypertension per se, and also the acceptance of the individual, because many women try to dismiss it. They will not necessarily accept it. And it becomes very difficult to control blood pressure with aging. This happens with both the sexes, but in women it is even more. And that's because in the period of menopause, the high BP is accompanied by the menopausal changes itself are accompanied by changes in the body mass index and the midlife weight gain. This is in particular contributory to a resistant hypertension. And estrogen, as we know, has multifaceted effects on the vasculature, and its sudden decline causes a low arterial compliance, and there is a resistant hypertension in postmenopausal women. And as I already mentioned, the body mass index is a very, very contributory factor. And diabesity, this is a new terminology which is coined. Many women also may have diabetes and a contribution from obesity as well. And the angiotensin 2, because it has a higher level, it is present in a higher level in the vasculature, causes an increase in salt sensitivity. So it is imperative that postmenopausal women reduce their salt intake. So these are all some of the peculiarities as far as hypertension in menopausal and postmenopausal women are concerned. So of course, a major contribution comes from the estrogenic decline, but these are other factors that need to be noted, particularly the resistance to treating hypertension, as a result of which it becomes really difficult to treat hypertension in course of time. And number 3, the increase in salt sensitivity and the body mass index. So these are all exclusive factors in women which need to be understood. Elderly women and hypertension is again another area, and it has been found in American studies that more than 90% of women crossing the age of 80 are hypertensive. So it effectively compromises the quality of life and the quality of care that an elderly woman will be able to get. She is highly prone for cardiovascular diseases and cerebrovascular diseases. Of course, hypertension is considered as an independent risk factor for sudden cardiac death. But at least sudden cardiac death with that, it gives a complete solution. But then caught in between in the form of cardiovascular diseases, heart failure. So it has a big bearing on the financial impact of the family and society at large. Next slide, please. Lifestyle. Lifestyle is a very significant factor. And we have to understand, even yesterday as I was talking to Dr. Muruganathan, there was one point that we discussed. It is true that when we ask a woman about the quality of her physical exercise, in general, I have listened to women say that they work for the major part of the day. They aren't telling a lie, yes. But the work is not contributory to their physical activities. It is not contributory to any kind of exercising. Yes, women usually play a multifaceted role. They have multiple roles, but that does not essentially mean that they care for their health. That does not essentially impact a good lifestyle. And lifestyle is about not only about the exercising. We must also remember that women have a greater proneness to stress, dietary insufficiency. Anemia is much commoner in women. Access to healthcare, vitamin D deficiency. Of course, racial factors. It has been proven that Blacks have a higher level of hypertension compared to the Caucasian or the European population. All these predispose women to hypertension. And it is interesting that apart from the decrease in sodium intake, an increase in potassium will also be contributing to reduce hypertension in women. Next slide, please. So pregnancy and menopause are times of hormonal upheaval. And to state in the most, the most miniature manner, estrogen and progesterone in pregnancy allow the cardiovascular system to accumulate so much of blood volume and cardiac output that is essentially in the interest of the fetus. But then this adaptive mechanism is totally lost when it comes to menopause. Next slide, please. So this is again another issue. As already I told you, biologically women are favored, which in turn means that women outlive men. Women live longer, and this again makes them more prone for being hypertensive and the complications that ensue. And elderly women always have much more severe hypertension. And this is in comparison, not only with men, but also in comparison with young and middle-aged women. It becomes difficult to control their hypertension, both from the biological perspective and, I repeat, a physician inertia. Physician adherence. The women may not adhere to the physician until they are thoroughly convinced, or there is a self-conviction that they have to take care of themselves. Inappropriate drug choice. And to give an example, many a time I have seen prescriptions still from the primary healthcare centers, etc., where women just come with atenolol, and that would be the only prescription that is given. So it's an inappropriate drug choice. And another thing to be remembered is women also have cognitive dysfunction and mood changes, not only on account of age, but because of a long-standing hypertension, which has been proven to produce changes as far as the cognitive part is concerned. They may go for dementia. So all these will definitely have an impact in taking care of hypertension. Next. Now coming to this issue of pregnancy and hypertension. This, of course, is something that really concerns the family, the woman, everybody, because it is going to have long-term consequences for the mother and more so on the fetus. So we categorize into chronic hypertension, gestational hypertension, preeclampsia and eclampsia, and preeclampsia, which can be superimposed both on chronic hypertension and gestational hypertension. So chronic hypertension is defined as a high BP above 140/90. This is recorded before pregnancy or before 20 weeks of gestation. And if it is after 20 weeks of gestation, it is called gestational hypertension. And as we all know, if it's accompanied by albuminuria, we go into the next category of preeclampsia and eclampsia. And at any point of time, it is always possible that preeclampsia gets superimposed on both chronic hypertension and gestational hypertension. Next slide. So this is the categorization on the basis of mild, moderate, and severe hypertension. Next slide. And this pre-pregnancy workup, it's very essential. As I already mentioned, a pre-pregnancy workup should include a good history. It should involve the family members. It's very, very essential. Because many a time, it is important to educate the husband, the family members of the husband, and of course the parents of the girl. And it is always necessary to search for the possibility of a secondary hypertension. And if the woman has been a hypertensive for a long time, it is also essential to evaluate the damage to the vasculature. Simple assessment, as I already told you, a good history, pulse, examination of the pulses, BP measurement on both arms, and of course, we give importance to the possibility of white coat hypertension. This is again another thing that I have experienced many of the times. And nowadays, with the availability of electronic BP apparatus, always it is necessary to insist that people get the BP apparatus because there is no observational error. Teach them the right way of tying the cuff and self-monitor BP. Quite a number of people have white coat hypertension. And so I always ask them to bring the recordings of BP at different points of time of the day, an early morning BP, because they give so much value. It's a value addition to the workup of the patient. And some of the simplest investigations that need to be undertaken to rule out a secondary hypertension could include just potassium levels, serum creatinine, because that essentially tells the possibility of primary hyperaldosteronism, thyroid profile, though I have not written here, serum creatinine, and of course, a cardiac assessment is essential, and urine PCR. So these are all some of the basic investigations that need to be undertaken in a pre-pregnancy workup. And whenever there is the possibility of a renal artery stenosis, a CT angio of the renal arteries can be undertaken. So all these are done in order to rule out the possibility of a secondary hypertension. And one important thing that needs to be remembered is sometimes the previous pregnancy, if the woman is coming for her second or third pregnancy, she may not reveal or she may not even be aware that she had a hypertension in the past. Here again, I would like to quote an example where I was called to give an opinion during my 24-hour duty to the obstetric department, where a woman had a miscarriage for the third time. And here again, when I examined the patient, and of course, I was called because she had a very high blood pressure. And exactly a repeat of the previous example that I told you, she had very high blood pressure in both the upper limbs with absence of pulses and absence of BP in both the lower limbs. She turned out to be a coarctation, and that essentially explained why she was not able to retain the fetus. So this is just to say that this woman, either she was not diagnosed or she did not know or refused to reveal the fact that she was a hypertensive during the previous pregnancies. So a history of a preterm birth or a history of a low birth weight, IUGR, may be very helpful for us to, or maybe the only clues that state that the woman has been a hypertensive during her previous pregnancy. And this essentially brings us to the possibility of a chronic hypertension in the woman. And in the situation where a woman is not still ideal as a candidate to undertake conception, it is very essential to talk to the family members. Recently, there was one patient whom we had after bad obstetric history. She was getting conceived. The whole family was excited. But during the course of evaluation, it was found that she was having a proteinuria. And we found that the patient had a chronic kidney disease. And it was with so much dismay that we had to convey the information that she could not carry on with her pregnancy. So all these are things that need a team effort and which needs the coordination of people around the woman. And in situations where the woman can postpone the pregnancy, adequate or ideal contraception is very essential so that further end organ damage can be prevented. Next slide, please. So what are the goals of treatment in a pregnant woman? There are so many studies, but none of the studies categorically state that this should be the ideal BP at which you start antihypertensive therapy, or what exactly is the target BP, which is very ideal. It has to be tailor-made for the patient. It needs the coordination of the obstetrician as well as the treating physicians. And it also needs to be understood that associated comorbidities determine when exactly to start treatment for the patient. So first of all, establish a diagnosis, whether it's a chronic hypertension or whether there is a preeclampsia which has been superimposed on the chronic hypertension. And what is the level of BP treatment that is needed for that particular patient. And of course, there are drugs which are very beneficial, and we need to use drugs effectively so that there is no adverse effect on the fetus. Next slide. So this is in general about how exactly to go about with the treatment of a non-severe hypertension. So as I already mentioned, rather than the target BP, we have to determine the treatment depending upon the symptoms. Sometimes the patient may just have a BP of 140/90, which is essentially mild. And there is the dilemma whether the patient really needs to be treated, because there is at the other end of the spectrum, it is also possible that drastic reduction in BP or even a BP which is brought down by 10 millimeters of systolic mercury, millimeters of mercury may cause a decline in the uteroplacental flow. So we go by the associated symptoms. So even for a mild rise in BP, sometimes the patient may be symptomatic. And we cannot dismiss white coat hypertension. So whenever the office readings are continuously high, despite the home recordings being normal, it's better to go ahead with treatment. And if there is target organ damage, or if there are comorbidities like diabetes or a thyroid disease, etc., these are situations which mandate starting treatment, and it is best left to the obstetrician and the physician who treat the patient to determine when exactly to start the BP. And we have to follow it up with serial recordings, both from the patient's end and from our own end in the form of office recordings. Next slide, please. So the therapeutics which are used in pregnancy, as we all know, the oral therapeutics include labetalol, methyl-dopa, and nifedipine. Sustained release medications can be used. And if it's a hypertensive emergency, that mandates that the BP is brought down if it's an acute severe hypertension within 15 to 30 minutes of diagnosis of the hypertensive emergency. And this is the target BP of 130 to 150/80 to 100 that essentially needs to be done. In fact, to put it more precisely, not more than 25 millimeters of mercury of mean arterial pressure, 25% of the mean arterial pressure. And the IV drugs are IV labetalol, nicardipine, hydralazine, which are preferably used. And the other aspects of treatment include, if a woman has a high risk of going in for preeclampsia, a low dose aspirin is given, preferably after the 12th week of pregnancy up to delivery. And it is also recommended that the woman is given supplementation of calcium of 1.5 to 2 grams per day from the second half of pregnancy, especially because women have a poor intake if there is accompanying vomiting, etc. Physical activity is essential even during the course of pregnancy, unless there is some recommendation which prevents her from undertaking physical activity. And very, very important is if the woman in a pre-pregnancy status has been on ACE inhibitors or ARBs or direct renin inhibitors, they need to be discontinued within 2 working days after the notification of pregnancy. Next slide. And aggressive lowering of BP is again at the other end of the spectrum, as I just mentioned. So the decision has to be taken with the patient and depending upon the associated conditions which the patient has. And in such a situation, excess lowering of BP can produce a decline in uteroplacental perfusion. And there is also the problem of unnecessary drug exposure to the fetus, which can be avoided. Next slide, please. And this is the next area, conveniently forgotten in many situations. I have quite a big number of patients who come to me and they are perfect in their follow. They maintain very good records in a neat diary. They bring all the credentials needed for monitoring of BP, but the moment the baby is born, you never get a feedback at all. So this is an area which needs to be insisted upon, because it is known that postpartum, 3 to 6 days later, the BP starts speaking up again. And if the BP is 140/90, above this at the time of discharge, it is better to start treatment. And treatment is like a non-pregnant patient. And we do take into consideration the breastfeeding status of the patient. In fact, even drugs like loop diuretics, if the patient has been edematous, can be given for a short period. And antihypertensive therapy should be continued for 12 weeks with a constant monitoring. And then we can try tapering it. Even if the patient has come to a normotensive status, it is imperative that we continuously have a hold over the patient, monitor the BP, ask the patient to maintain a home monitoring, and follow as frequently as possible, because this is the stage at which these people can go into a state of chronic hypertension. And during the follow-up, the other aspects like hyperlipidemia, insisting on physical activity, avoiding sedentary lifestyle, and in case of obesity, all these aspects need to be addressed during the follow-up. Next. And now, so we have gone through the pregnancy part, the postpartum part. Now coming to the next important status in a woman's life, that is the perimenopausal and the menopausal states. And it is interesting to see how BP behaves in women at this period of time. Hypertension incidence rises precipitously. As already mentioned, you find that the woman has essentially been normal. And now postmenopausally, there is a sudden increase in the BP. And again, it's related to the body mass index. It's very important to note that. And postmenopausal upregulation of renin-angiotensin system. And so salt reduction is very essential. And it is interesting to note that postmenopausal women have more variability as far as the ambulatory monitoring of BP is concerned. And nocturnal dipping is something that happens physiologically in all of us because the sympathetic activity is low during the night. So there is a reduction in BP by 15%, but a less than 10% drop in nocturnal BP is something that has been known in postmenopausal women. And this is one important reason for the poorer cardiovascular outcome and a higher level of target organ damage when compared with that of men. And a high systolic BP is associated with a higher degree of stroke in women compared to men. And an untreated high systolic BP, again, is one of the harbingers of cognitive decline. So these are all some of the maybe interesting for us, but it's really sad that if a woman does not take these adequate steps during her menopausal period, these are all some of the problems that are likely to happen. Next. So we have to consider starting antihypertensive therapy. We have to advise on her lifestyle. A woman has to undertake vigorous physical activity, especially during her postmenopausal period. And some of the important things we need to consider before starting antihypertensive medication is, number one, cardiovascular reflexes. Again, they are much more affected in a postmenopausal women when compared to men. Falls in the elderly are common irrespective of gender, but women are more predisposed to falls. Maybe it's because of the lower muscle mass. And secondly, it's because the cardiovascular reflexes change more than that of men. So this is an important area that needs to be addressed when we start an antihypertensive therapy. And of course, I have not mentioned here because of the orthostatic hypotension. And during the first 45 days after initiation of antihypertensive therapy, there is always likelihood of initial hypertension and injurious falls are possible, especially in women 65 years or older. So this is to be insisted upon. They have to be taught all these things. The family members need to be apprised. And I'm sure in quite a number of homes, wherever it is affordable, nowadays the toilets are fitted with holders. And all these are small things, but they go a long way in enhancing a support system and also gives confidence to the woman, and it can to a major extent prevent falls in the elderly. Next slide, please. So what is the pharmacotherapy of hypertension in postmenopausal women? So the amount of BP reduction is a major determinant in the reduction of cardiovascular risk. Irrespective of the antihypertensive drug, the most important thing is reduce the BP. And comorbidities always determine the choice of the antihypertensive therapy. Calcium channel blockers may be used as the first line drugs as a monotherapy, particularly amlodipine, long-acting dihydropyridine calcium channel blocker, because it has an impact in reducing stroke. And for mild hypertensives, initial diuretics, thiazide-like diuretics, particularly chlorthalidone or indapamide, are preferred. Of course, we know that they can cause an imbalance of sodium and potassium, and even that is supposed to be much more in women compared with that of men. But still, these are the preferred first-line monotherapeutic drugs to be started. In general, beta blockers are not used as initial monotherapy in both the genders. That's because of the adverse outcome, especially in people above 60 to 65 years of age, because beta blockers act by reducing the cardiac output. And so these are some of the ways in which we decide about pharmacotherapy. And as already mentioned, we take the appropriate precautions and we follow up. Sequential increase of dose is important. So after starting, say for example, on chlorthalidone of 12.5, we wait for 4 to 6 weeks period, ask the patient to come back. Meantime, the patient would have monitored and had brought a record of the home monitoring of BP. We make office assessment of the BP and then step up to the next dose. But in general, it has been seen that stepping up the dose essentially enhances or increases the side effects rather than having a better antihypertensive control. So the message here is that rather than increasing the dose, always insist on the non-pharmacological aspects of management, which includes reducing the salt. And this is very, very important, and replacing with potassium salts. Take more of potassium containing foods, fruits, tender coconut water. All these are things that as long as the woman has not got any other associated problems, she should be encouraged to and undertake vigorous activity. All these things are very essential rather than just going in for increase in the antihypertensive therapy unless mandated or unless there are associated comorbidities. Next slide, please. And there are 6 differences. It's very interesting again, relating to antihypertensive responses and also relating to the antihypertensive adverse reactions. Thiazides, women are more prone to develop hyponatremia and hypokalemia when compared to men, whereas men on thiazides are more prone to develop gout. And there is another interesting study with relating to losartan. The name of the study is here. It has been noted that there is a greater LV mass reduction and lesser incidence of stroke and a decrease in total mortality in women, though there is an increase in hospitalization in women for angina. ACE inhibitors are known to produce 3 times higher risk of cough in women. And the dihydropyridine calcium channel blockers, particularly amlodipine, causes more edema in women than men. I have never seen, I have had quite a number of men patients on amlodipine. To this day, I have not seen pedal edema in very rare cases, but women, quite a lot of them come back with edema. Though amlodipine has a higher antihypertensive effect when compared to the same dosing in men. And minoxidil is not used as a first-line drug. It is used only in resistant hypertension, but when used, it produces hirsutism in women. Next slide. And there are 6 differences. All these things happen because there are differences in the pharmacokinetic properties and the pharmacodynamic properties. And this is just to give an example. There are certain enzymes like cytochrome P450, CY, cytochrome P2, D6, and these are supposed to be responsible for the difference in the pharmacodynamics when it comes to certain drugs in women compared to that of men. So for example, beta blocker, particularly metoprolol, it has been studied, it produces greater adverse effects in women. That is because of this particular metabolic pathway and its impact in women. So for a 50 milligram dose of metoprolol produces, 100 milligram dose of metoprolol in a man is supposed to be equal to that of a 50 milligram in a woman. So this is just to state how much of difference exists at a molecular level. That is because of the pharmacodynamic and kinetic properties of the drugs. And difference in pharmacokinetics has been noticed in the form. An example is the clearance of verapamil and amlodipine. And in general, there is a higher degree of adverse effects to antihypertensive medications, and they are much more severe in women when compared to that of men. Next. And at this point of time, though we have been talking elaborately about the pharmacological aspects of management, equally, I would like to insist that it's very, very important to keep talking during every visit to women relating to the diet, lifestyle, physical activity, salt intake. So this, and to reduce the body mass index and to concentrate on this obesity part of it. So this is definitely going to take a major chunk and play a major role in bringing down the hypertension. And as we all know, DASH therapy is dietary approach to stop hypertension, and details of the diet, rather it is DASH diet rather than therapy, is all available. And this is very effective. And one interesting news, all along we have been talking about pharmacological aspects, and we found that it is not necessarily good news for women, because many of the drugs seem to be having a negative influence, or rather more complications or more adverse effects in women compared to that of men. But at the other end of the spectrum, it's so interesting to note that applying this DASH diet in women has a better responsiveness in women compared to that of men. And this is known to produce a lowering of BP, not only in hypertensives, but also in non-hypertensives, both in women and men, but seems to be better in women, as it has been noted that the systolic blood pressure, which has been recorded after a period of time, is much lower in women when compared to that of men. And it is even more interesting to note that this kind of a dietary schedule improves the mood and also the cognitive aspects in a postmenopausal women. So all these things are to be taken note of very seriously. And again, I have mentioned here because salt sensitivity, it has been repeatedly mentioned, because these are areas which need to be insisted upon at every visit when especially postmenopausal women come with hypertension. Next slide. And this is again a study, an interesting study, a nurse's health study, where women above 58 years were examined by maintaining normal body mass index and eating diet rich with fruits, vegetables, obviously containing more potassium, low fat dairy products, low sodium, with vigorous, a big schedule of physical activity, non-narcotic analgesics. As we all know, NSAIDs can produce hypertension, supplementation with folic acid, and having a note on the anemic status, improving the iron deficiency status, vitamin D supplementation, reducing smoking and alcohol consumption. So this study has found that there has been a big impact, and this has helped women to maintain normal BP, especially the study conducted after 58 years to 68 years, if I'm right. And it has had a huge impact on the health of the people on whom the study was conducted. Next. So there are many aspects which are detrimental to women and their treatment. First of all, it is the lack of awareness in the woman per se, in the society at large. In general, women, it is considered that men suffer more when it comes to hypertension or cardiovascular diseases. But now we find that it is not so. Women have a greater proneness, and this lack of awareness also exists among the healthcare providers, and they need to aggressively lower the BP. And it's also important to note that compared to women, women receive less pharmacological therapy for the management of cardiovascular risk factors. And it is mainly because of the fact that women present with coronary ischemia much differently than men. We all know that many times women will come with GI symptoms, whereas men may have typical features of angina. So this makes it easier for men to approach a professional help compared to that of women. And as a result of this, women are less likely to be diagnosed early and sent for therapeutic procedures. And the prognosis of women, if she goes in for a cardiovascular disease, is definitely worse when it compared with that of men. And as Dr. Nathan had stated, the cohort studies and the RCTs were all initiated during the mid-20th, that is during the middle of 1900s. And during the initial phases, many of the studies, in fact, many of the drugs which are used during the time of delivery, all these drugs have been studied in men rather than women. All the drugs which are supposed to be used for women were also studied in men. So this was the status at least 50 to 70 years back. But now a study will not be approved if it does not include a sizable population from both the genders, ethnic groups. So they need to have geographical representation. So otherwise the study will not be complete. So all these changes have been noted and appropriate reparations are being made. But then initial cohort studies and RCTs have not been essentially supportive for women when it came to treatment of women with drugs. Next slide, please. So this is a very general slide. So this is just to say how to select antihypertensive therapy in elderly, but this is not very specific for women. But when it comes to women, two simple things I would like to say are, yes, women without any comorbidities, they come to us for the first time. If it's a mild to moderate hypertension, again, start with non-pharmacological measures, insist on non-pharmacological measures, ask them to reduce the salt intake, ask them to maintain a diary of home monitoring of BP, increase their exercise and change their diet and have a positive outlook and change their lifestyle. And preferably, she can be started on thiazide diuretics or thiazide-like diuretics, because one of the interesting aspects of thiazide-like diuretics, that is chlorthalidone or indapamide, is that osteoporosis is drugs which are helpful in osteoporosis. The hip fractures are lesser, the falls are lesser, and that's not about the falls. It is because in the distal convoluted tubules, these drugs enhance the absorption of calcium, so it prevents osteoporosis. So if a choice has to be made in a woman who does not have any other comorbidity, this can be the first line of therapy. And in general, the long-acting calcium channel blockers, dihydropyridine calcium channel blockers, especially amlodipine. Of course, the only problem is the edema. Otherwise, it has a better antihypertensive effect in women, so they can be taken up as the first lines of therapy. And of course, the three groups of drugs which always find priority as the first monotherapy include the thiazide diuretics, the calcium channel blockers, and the ACE inhibitors or ARBs. And of course, we have to select on the basis of whether the individual also has associated comorbidities. Many of the times you find that the patients also have diabetes, proteinuria, in which situation we would prefer to go for ACE inhibitors, ARBs, etc. So this should be the basis on which we select antihypertensive drugs. And as already mentioned, preferably beta blockers in elderly patients above 60 or 65 years are not started on beta blockers. And so there are other groups of drugs like alpha blockers, which are never recommended as initial monotherapy unless it's an older male with hypertension, with prostatism, and of course with no cardiovascular risk. So we have so many permutations and combinations of symptoms and comorbidities and associated features, which are taken into consideration before we decide what should be the appropriate therapy. Always we go slow on the therapy, start at the minimum dose, monitor the BP, observe for first dose hypotension, always be watchful about orthostatic hypotension, and equally give insistence about bringing home monitoring of BP records and non-pharmacological measures. Next slide, please. And we also need to know that which are the combinations which are preferably avoided. It's not only about the combinations which need to be given, but also to be avoided. Here there is a small list like ACE inhibitors with ARBs. ACE inhibitors and beta blockers, of course, we do give, but then there are certain studies which state that the beta blockers act effectively on the renin and the angiotensin. And so the ACE inhibitors and ARBs may be less effective when given with beta blockers. There are certain studies supporting this also. And beta blockers with non-DHP CCBs, because they potentiate the cardiodepressive effects of the beta blockers. And ACE inhibitors with mineralocorticoid receptor antagonists, because both of them combined together will produce hyperkalemia. So this is not conclusive and this is not a complete list. This is just to bring an idea as to how exactly to go for combinations, because many a time, as already mentioned in one of my previous slides, the appropriate choice of antihypertensive is not done, and that is one among the reasons for treatment failure and the development of resistant hypertension, particularly in postmenopausal women. Next slide, please. So take-home messages. Women need to be educated. High blood pressure is a greater problem, not only for the woman, for the family, for the society at large. It has huge financial implications. So women need to be taught about the importance of the BP, about self-monitoring and therapeutics. And pregnancy and hypertension needs patient and family education because it is not just stopping with the delivery. It needs a regular follow-up after delivery. Vigorous physical activity is essential for women if they can afford it. And maintaining ideal body mass index, they have to consciously maintain the body mass index and keep weight at a very, how to say, that is, they should not go into a state of obesity because that is always a problem, especially in a midlife period, and it's a midlife crisis. And salt restriction is very essential in postmenopausal women, and they should be encouraged to take potassium-containing foods. Of course, if their renal status is normal. Orthostatic hypotension always needs to be ruled out before starting antihypertensive therapy, and beta blockers are not used as first-line monotherapy, and since they act by decreasing the cardiac output, and it can negatively affect people above 60 years. So it's a combination of all the pharmacological as well as the non-pharmacological measures are concerned. But at the end of all this, I would again like to insist that education is very important. It's about educating people and it's educating ourselves as physicians. And it is very important to note that there are certain things which can be highly modified and the quality of life can always be given in a very good manner, and women can lead a very good quality life if properly advised and if the advice is taken in the right sense. Next slide. So to end, this is something which I always love, and Hutchison's statement is not new. I'm sure most of you know, and this is at least 70 years old. And it's phenomenal that at 70 years back, how much this man has thought of. From inability to let well alone, from too much zeal for the new to contempt for the old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. And this is very important because hypertension is something that is correctable, something that can be prevented, and something that can prevent grievous injury to the person if properly approached and properly treated and properly recognized. So with these words, I am very grateful for the platform given to me. Thank you very much.
Thank you, Dr. Geeta, for that excellent presentation. As usual, you rock. Now we'll go for the Kahoot. I'm glad a lot of women have come. I think Vidita has joined. Meenakshi Dar is there. So I'll give the game pin. In the meantime, Meenakshi, are you there? Meenakshi Dar? Please get ready to join. I'll give the game pin now.
Yes, I'm there.
Yeah,
I'm just
624164. Yeah. Okay. As they are logging in, your quick comment, Meenakshi, about the presentation. Anything you want to add now?
Yes, sir. It was an excellent presentation, as you already had declared beforehand only. And really, we learned a lot of new aspects about women. Truly speaking, I did not have such an insight into this, that this is one field where we need really to work upon. And thank you for bringing up this. And it has given me a lot of ideas of working in this field, because we see so many females coming to, especially the ones who are accompanying there, because I run a geriatric clinic also. We have so many elderly males who come along with their wives, and the wives just come to, because they happen to be slightly younger than the males, and they are more worried about their males' health and health issues rather than their own. So I learned one thing, that I should, even if they don't make a card, I should just make a chance to check their blood pressures and let them know that they may be suffering from hypertension. That was an excellent actually information, which I think we all should carry. And as usual, Madam was so basic in her knowledge, and probably she I think as we advance in our careers, we stick to the basics, And that is, that we keep on telling our juniors that please stick to the basics. And that is what ma'am did today. And it was an excellent talk. And really, she revised everything which probably most of us have forgotten. It was really nice. It was good.
Thank you, Meenakshi. Anyway, my one message has gone to you. By educating one person like you, intelligent person, it's equal to educating thousands of people. So I'm glad you will start.
Thank you, sir.
You will start checking the blood pressure of the spouse who accompanies the man. I think already Prabhakar is doing that, but anyway, I'll request Prabhakar also to do that. Now I'll give 3 seconds before I start the Kahoot. Yeah, whoever wants to join, please join. And as usual, Hemant only join first. I don't know what trick he has. Now we'll start the Kahoot. I'll count 3, 2, 1. Here is your first question. Which antihypertensive drug has an advantage in treating postmenopausal women? CCBs, thiazide diuretics, ARBs, beta blockers. In postmenopausal women. Thiazide diuretics, Geeta was talking about osteoporosis, especially thiazide, conserve calcium. So it's good for postmenopausal. Karthi, Yogesh, and Shivangi. The nocturnal dipping pattern of blood pressure is blunted in men with hypertension, postmenopausal women, chronic hypertension during pregnancy, gestational hypertension. Nocturnal dipping pattern of blood pressure is blunted. Yes, postmenopausal women. That's why you should do ambulatory blood pressure monitoring, because that's a dangerous thing for women, for them to develop all complications. Now the third one, BP elevation has been associated with the concentration of in OCP, oral contraceptive. Is it ethanyl estradiol, methinyl estradiol, toxoprinin, or none? Concentration of yes, ethanyl estradiol. Now scoreboard again, Shivangi, Vijay, and Lebetalol. Oh. If a person with chronic hypertension on ACE or ARB becomes pregnant, they need to be discontinued within a week, within 4 days, within 2 days, or within fortnight. Within 2 days. It is always prudent not to use ACE and ARB in the reproductive age. Why wait and then remove? Which is the most preferred CCB in pregnancy? Icardipine, nifedipine, amlodipine, verapamil. Most preferred CCB in pregnancy. Yes, it is nifedipine. Again, Lebetalol, SR, Rekha. I'm very curious to know what's the name for Lebetalol. The person must identify. The benefits of estrogen in preventing hypertension are due to the following, except increase the production of endothelin-1, increase the level of angiotensinogen, increase antioxidants in the vasculature, increase the production of nitric oxide. This is except the benefits of estrogen. Yes, increase the production of endothelin. Except that, all the other statements. Again, Lebetalol, Silvaganapati. 7. Which statement is not true about DASH diet? Lowers BP, both hypertensive, non-hypertensive, improves mood in menopausal women. Women respond better than men to the above dietary pattern. It does not include dairy products. Which statement is not true? Yes, correct. Dash always includes low-fat dairy products. But lol, SR, Selvagarabadi. Now, which of the following statement is false? Prognosis is poorer for men than that for postmenopausal men with hypertension obesity. Healthcare providers lack awareness that women with hypertension need aggressive BP lowering. The incidence of hypertension rises more precipitously in women than men. Untreated systolic hypertension in women is associated with cognitive decline. Which is false? Which statement? Yes, prognosis is poorer for men than that of postmenopausal women. In fact, prognosis is better for men compared to postmenopausal women with hypertension obesity. Lebetlal, SR, SIBA. Now, ninth question. The following are causes of secondary hypertension common in female except fibromuscular dyspepsia, coarctation, Turner syndrome, achondrosis. Common out of 4, one is not that common, though it may occur. Yes, except coarctation. I think the Gita's one incident made all of you to write the wrongly. Because Gita had one rare case of a coarctation in her OP practice. So she mentioned that. So probably you would have thought coarctation is more common. Lebetlal, SR, and SIBA. Okay, 10th question. Which drug is preferably avoided as first-line monotherapy in hypertension above 60 years without any compelling indication or specific indication? ARB, beta blocker, CCB, thiazide. Super. Let's see. Lebetlal, SR, SIBA. Now, the 11th question. Which sentence is correct in pharmacological treatment of hypertension in women? Combine aerobic and resistant exercise. Women may experience more antihypertensive side effects. CCB more beneficial in women for stroke prevention. All of the above. In pharmacological treatment. Very good. All of the above is right answer. Lebetlal, SR, and Selvagarabadi. The last one. Which sentence is incorrect in the non-pharmacological treatment of hypertension in women? Non-pharmacological. Salt restriction may not affect BP after menopause. Weight loss after midlife weight gain is advantageous to women. BMI is important determinant of hypertension. Combine aerobic and resistant exercise reduce arterial stiffness and BP in postmenopausal women. Yes, salt restriction. They are all salt sensitive. So salt restriction, that is the false statement. Now, let's see who are the winners. The third one is Selvagarabadi. Second one is SR. First one is, I want the Lebetlal to give his name and courier address with mobile number. Otherwise, I will post it to Lebetlal. I'm glad today all the 3 are new. Last time we had duplication, like Rekha, the 5 webinars, she came in first 2 times. So luckily or unluckily, Rekha is not there today. Okay, I'll now stop sharing and we'll go to the Sadanand Sethi. He has got only 2 slides. So let him initiate the discussion after Prabha.
Should I put that, or we can have initial discussion? I think it's already 10.
No.
Want me to on that? Yeah.
Sadanand, because you have given the 2 slides, at least I show the slides now.
Yeah. Just go to the other slide first, Mega. The first slide.
Okay, no. I have. Mega doesn't have. I get the slide.
Okay, go to the other slide first, yeah. I mean, first of all, I must compliment Geeta. I think, she covered, it is almost like a, hypertension, good way of presentation, like, premenopausal, menopausal, hypertension. That's a broad thing, yeah. This is the one, This I just read few days back, this is a French registry, and almost, 26 lakh of primiparous women. And they have seen, from 2010 to 2018, 8 years of the follow-up, and basically hypertensive disorders of pregnancy and onset of chronic hypertension. So point here is, who are the people, post-delivery are likely to get the chronic hypertension? That's the point. What is, the highlight of this particular, this is a conception study, or the registry, we can say. So basically, in 26 lakhs of, primiparous women, about 11 lakh plus at a gestational hypertension, about 66,000 plus at a pre-eclampsia. And when you see in the post delivery, that means, what I was mentioning earlier, like a 3 trimester, we know the 4th trimester is up to 3 months after the delivery. So that is like what is called as the 4th trimester. And when you see the hazard ratio of developing chronic hypertension in this group of patients, who didn't have hypertension disorders of pregnancy, I think incidence is around 3%, whereas gestation is around 6%. Means the adjusted hazard ratio, if you see here in the confidence interval. And patient who has a pre-eclampsia is about 8.10, the adjusted, suggesting that both gestational and pre-eclampsia are important risks for developing chronic hypertension after delivery. In that also, if you got gestation plus pre-eclampsia together, it is still high. And in the pre-eclampsia, early pre-eclampsia, severe pre-eclampsia with a gestational hypertension have, the bad outcome, in the sense chronic hypertension in these individuals are, in this primiparous woman is more. So here basically hypertensive disorders of pregnancy, that is called HDP, increase the risk of developing chronic hypertension in primipara women in the first year following delivery. So essentially, the highlighting the gestational, pre-eclampsia and together. The other slide, So what action we could take to what knowledge we got from this registry and how to apply that. And basically, as it is shown, like a hypertension during pregnancy, we have a gestational hypertension beyond 20 weeks. We know that. If there is a proteinuria, we call it as pre-eclampsia. Then pre-eclampsia with a gestation. It may start with a gestational and then may go into pre-eclampsia. The early and the severe pre-eclampsia, again, more increased risk of permanent hypertension. And the duration of hypertension pre-eclampsia also is very important to get into. Increased risk of permanent hypertension after the delivery. That means the 4th trimester, beyond 3 months after the delivery. So gestational hypertension is a risk factor. Pre-eclampsia, early, severe and prolonged pre-eclampsia, plus pre-eclampsia with the gestational, the risk for permanent hypertension. So basically the action to be taken that during every pregnancy, every prenatal visit, we have to screen, we have to prevent hypertension associated complication during pregnancy. And then of course the healthcare team and the patient, etc., should be, as Geeta rightly mentioned, after the delivery, everything is forgotten, and that is not the end of it. So the 4th trimester, the initial 3 months, particularly in the people who have got hypertension during pregnancy, is important to follow up so that, we are not missing hypertension, so that at least the hypertension related complication we can easily prevent. Of course, chronic hypertension is before the 20 weeks. We know that. That is another issue altogether. But when you talk about hypertension during pregnancy, these are the 3-4, gestation and all. So the highlighting the importance of gestational hypertension, and then in a combination of gestation with eclampsia, pre-eclampsia, more severe, early and longer the duration pre-eclampsia, bad outcome. So these people have, we will have to follow them up beyond the 4th trimester, the 3 months post delivery, and then accordingly we'll have to need it. So this is other,
Yeah. In continuation of your comment, Sadanand Sethi, the pregnancy adverse outcome history.
Yeah.
That is the most important thing you must elicit in the history. Those are the people who are going to develop cardiac problem. See, I have got a slide where they compare. So if there is a pregnancy adverse outcome history is there, they are the people who are going to develop more cardiovascular problem in the future.
Exactly.
So that is why we must ask the history of preterm delivery and short gestational age and IUGR, all that.
Exactly.
If that person has got any such history, you must be very careful because these people will definitely develop cardiac problem later.
Exactly. That, again goes like it's something like a tryptophan gene or something that, we have these histories, as you said, we are always including in that. The other thing, I just wanted to add just before going to Prabhakar, what this Geeta mentioned about it, around the menopausal time, it is not only hypertension, all the lifestyle, the dyslipidemia, I can tell you, just before the menopause starts, your lipid, everything is normal. But moment the menopause, within few months, it can change so much, yeah. In the sense, the estrogen, and the this hormonal effect in a female, and around the menopause, entire chemistry changes. Hypertension you develop diabetes, you develop dyslipidemia, because all these what she mentioned about the RAS, sympathetic activity, the positive effect of estrogen, and when once it is lost, how much it is important for the all the problem. Yeah. So this is again very important thing we must remember.
In continuation of your comment, low HDL is more risky for women compared to men.
Correct.
So low HDL also you must and Prabhakar is itching to answer and Chipping. Please, Prabhakar, please.
No, sir. Actually, first, let me congratulate Dr. Geeta for going through the entire chronology of hypertension. Basically, that's how I think her talk should be. She took it in the chronological order according to age. It was beautiful. Now, first, let me comment on what Dr. Shetty said. Actually, that is a very important registry which stresses only one point, that if you develop pregnancy-induced hypertension, those are the people where you should strictly institute lifestyle modification and tell them during pregnancy. If you don't do that, you're missing a very good opportunity of prevention of heart disease, which we don't do. And one of the very important things what I do is I make sure that all the patients with pregnancy-induced hypertension have a BP apparatus and check BP at home. Once they normalize, I tell them you keep checking at least once a month. And that goes a long way in prevention of subsequent hypertension and heart diseases. Now, coming back to what all the other topics she has said, she had covered beautifully about several secondary aspects of hypertension, but still I remember one thing, you have to search for the secondary causes. And this point about coarctation, she's been stressing everybody. I think it was Hutchison which said that any hypertensive who's young is coarctation unless you disprove it by checking the lower limb pulse. So that is important part and parcel of every clinical examination for hypertension. And very interestingly, I learned one point. Why do women always remember all the old things about those things that happened? That is because estrogen seems to be working on the hippocampus. That is something very new I learned today.
Yeah. Estrogen has got so many things apart from that hippocampal thing.
Many things I think we learned from Geeta. I agree with you. Yeah, because many
and
things...
so before I forget, Prabhakar and Sadanand, Geeta said losartan is good for women. At the same time, valsartan is very bad for women. The morbidity and mortality using valsartan is bad compared to men. And one more thing, ACE and ARB, if you use for women, not for reproductive age, just for hypertension, they induce more sex. Sex induction is there. This is the sprint trial, they found out ACE and ARB sometimes, more sex stimulant for women, not men. So, these are the things, which I think one should remember. Anyway, I'll go to the question chat box.
One point about the RAS inhibitors.
Yes.
The action of RAS inhibition, the RAS activity comes down as age advances. That is the reason why the RAS inhibitors are not the drugs of choice after 55 years of age or postmenopausal. Because that beyond an age, it doesn't work. And that is where the calcium channel blockers and the diuretics come. Now, one important point you must remember is you have stressed a lot on the salt restriction. And you've also insisted that these patients should be on some amount of diuretics. Now, you have to exercise caution there. Don't go overboard because there are so many patients where we see with hyponatremia, which cannot be forgotten. So generally avoid restrict salt, but don't go overboard on that. You have to tell them avoid excess salt is fair enough.
Yeah, but only thing, Prabhakar, that point, I think what she, because the postmenopausal and this, even menopausal men, hypertension in general, this salt sensitivity, particularly very important for us Indians, and that is why, the salt restriction in the diet. So also using small dose of diuretic, and luckily we have now, all these chlorthalidone or even indapamide, small doses are available, and basically elderly is like this, the like what NICE guidelines says, beyond 55 is more like a low renin hypertension. Low renin hypertension means
Right,
diuretic
right.
and CCB, either single or in combo. And less than 55 years, which may be 10 years younger in our Indians, so it's a high renin hypertension. So maybe RASI, that is your ACE or ARB, and then combination of ACE ARB with CCB like that. So that is probably the general rule. And of course, like what Geeta has given so much, things about the drug. If you go by that, prescription writing will be really difficult, yeah. Because so many things,
No, actually, one
Yeah.
important thing what Geeta mentioned, I also read. 50 milligram of metoprolol usage in women is equal to 100 milligram of metoprolol usage in men.
Yeah.
So even after dose if you give, they act better. So sometimes, some drugs you can give less, some drugs you have to give more. So women is very difficult to understand. And
Yeah,
with
yeah.
biological and chemical and biochemistry, everything is, you cannot understand.
But unfortunately, one other thing I always talk about when it comes to male and female,
Yeah.
I say female, like male, we have got only 4 alphabets. Female have got, 6. They're this. E and she, again, she is better than E, And then comes the men and women, again, they are better, But unfortunately, we men put them as a second-grade citizen. That's why, husband is brought to the clinic regularly, but wife never get checked, what you said, Very
That is
true.
why that one point I wanted to stress. So I'm happy every one of you have picked up. So next time you get one more case for you. Also detect a new case. So that's why I thought that's an important opportunity screening. We always public health point of view. We'll always say opportunity
I
screening.
think very important point. I mean, of course, you are told earlier also, but I think this is what we are, at least currently we are making as a routine. And even if you don't charge, at least, keeping at least a check on BP, But
We can give RD discount for one male checkup, one female checkup is free. So at least female can be checked up easily because females don't want to spend anything for their health. You can always say when we are checking the men, the female automatically comes as a family package. Okay, coming to the chat box, Monica Gupta, my good friend from Benares, excellent deliverance, madam. In a peri or menopause woman, we have to use anti-anxiety add-ons to control the blood pressure. What is your take on usage of anti-anxiety along with antihypertensives and rest therapies? Second question, would you recommend to use propranolol as antihypertensive in women as first-line therapy in hypertension with tachycardia? I think Prabhakar, you answer first, then I'll go to Geeta.
Sir, I didn't get the first part of the question properly.
The perimenopausal and menopausal women, do you use anti-anxiety drugs?
Sir, unless I clinically feel they are going to be useful, I don't use anti-anxiety. In fact, my usage of alprazolam or Angsit is hardly anything. If I feel that there is an issue, I use the antidepressant that I use generally is only sertraline. That too in post-myocardial infarction where I notice a problem. But perimenopausal, menopausal, if they have a problem, unless I really see, I really don't touch any of the antihypertensive.
Why Monica is asking, because of the hormonal changes, cognitive problems and all that, they may have depression, they may have anxiety and things like that. So in those cases, when they have hypertension, is there any role for anti-anxiety drugs? That's what Monica wants to know. Sadan said, your view?
No, basically, I think, this is it is a very apt and right. I think our question is quite right. In such situation, we may have to give for some short time, I agree with her because we can't just leave her only on the medication. If she's anxious, which is again hormonal, depressive, and of course now, it's more like a multi-speciality, like we may have another, consult with the whatever, the psychiatry, whatever it is. But I think we as a physician can give, I feel, there's no harm, particularly all these alprazolam or maybe the lorazepam and, all these drugs, small dose should not be a major hindrance to the.
I think I'll ask women, Meenakshi, in the post-menopausal woman, they have flushing and all sorts of, mental depression, things like that. What is your take on anxiety drug, Meenakshi?
So to be frank enough, the first thing is, as everybody's saying, that history taking is very important. If we are suspecting or if we diagnose that patient is having anxiety or postmenopausal symptoms, it's always better to add on some anti-anxiety, but what I prefer is either a short-acting benzodiazepine for a short duration or amitriptyline and give it a short course. If the patient does not respond, then I would definitely consult a psychiatrist, because these are the age groups when the neuropsychiatric disorders are very common, and these antipsychotic drugs are used slightly more often than they should not be used actually, and unless until we don't have a specific diagnosis. So I prefer to give a very short course of short acting benzodiazepine, and if the patient responds well, then it is fine, and if he doesn't respond, then or she doesn't respond, I always prefer to take a psychiatry opinion.
Prabha, there's a saying, women understands women better. So that's why I asked women about the anti-anxiety. Now, the second question, would you recommend the use of propranolol as antihypertensive in women as first-line therapy in hypertension with tachycardia? Sadhan Sethi?
No, generally, because I agree, all those propranolol, generally anxiety, then your tremors, even in Parkinson's, this thing, etc. The migraine. These are the original indication of the propranolol. It is said, but I don't know. We use that drug, at least I don't use at all propranolol, because I always go for the newer generation of beta blocker. I don't want the non-selective in these patients, unless it is for a short time. If you're using for just a some reason for a short period, it is okay, but not as an anti-hypertensive drug. I won't use as an anti-hypertensive.
Prabha, any comment?
The only addition is for an antihypertensive effect, you have to use a much higher dose. What we commonly use is 10 and 20 milligrams, which is not going to reduce the blood pressure. And that probably will reduce your anxiety a little bit, the palpitations a little bit. If they have a mitral valve prolapse and you think that is contributing, that is the only other additional indication. Others, I think Dr. Shetty has clearly highlighted.
Also, one more additional thing, migraine. If suppose they have migraine.
Yes, migraine.
Yeah.
The only thing is short acting, sir. Basically, sustained, prolonged release preparations are available. But today we are talking about beyond 24 hours control and all. I personally feel selective beta blocker should still work there.
And beta blockers, one more thing for the women. Most of the women postmenopausal, they are not only hypertensive, they are obese. So beta blockers, tend to put on, it's not weight neutral. Sometimes, that's also another thing which you have to use. But nebivolol, the latest paper, they say they are very good for lipolysis. The recent article, B3 stimulant and nebivolol is supposed to be good for these situations. There is a new article.
That is why even our Indian guideline of hypertension, even, your other Western guidelines also, among the beta blocker, nebivolol is the drug which is recommended because of the NO, nitric oxide, and
B3,
yeah,
stimulant and nitric oxide, lipolysis and all that.
Nitric oxide, highly selective, is among the beta blocker. The maximum selectivity is nebivolol. Then comes a bisoprolol. So therefore, even in people who have hypersensitive lung disease or a COPD, or even for that with asthma, small dose of nebivolol can be still given. So our drug of choice in hypertension, uncomplicated, is nebivolol. I agree with you.
For Balaji, for a gestational hypertension patient, what is the drug of choice in postpartum period? Shall we continue labetalol or should we switch over to ARB or CCB? If to switch over means, shall we stop beta blocker abruptly and start the new drug? Sadhanand, because you were saying about the fourth trimester, tell me.
No, post, I think, we should not be worrying about that period of, the whatever, is or ARBs and the other things are already over, So I don't think we should worry of treating hypertension, post-delivery, unless we are talking about, a release of this drug in the breast milk and all. But otherwise, I don't see any reason, whatever is depending upon the degree of pressure, and maybe suppose patient is edematous, even a small dose of diuretics are recommended, even around this period. Otherwise, again, I would say I would go by conventional, like young people, high renin hypertension, older people, low renin hypertension. I would go with the same principle. Younger people, any RASI, ACE, ARB plus CCB if required. Elderly, as I mentioned earlier. So here, young patient post delivery. So maybe RASI, ACE inhibitor, ARB. Generally, as an hypertension, for an hypertension, I use only ARB. I don't use ACE inhibitor because of that cough nuisance and all. And we have got so much of meta-analysis today. I don't think ARB is anyway inferior to ACE inhibitor. Because
especially ACE inhibitor will produce 6 times more cough in women.
Yeah, 5 to 6 times. Yeah, 5 to 6 times more in females. So possibly, long-acting any drug, which are like, the most common drug is again telmisartan, or if you are favorable, maybe olmesartan, etc. and if required with a CCB or maybe with a small dose of chlorthalidone and so on.
Can clonidine and moxonidine be used in pregnancy?
No. I don't think we are using it.
Yeah, the reason is, moxonidine, clonidine can cross the placental barrier.
Yeah.
It can produce bradycardia in the fetus and can produce problems. But in the rat and all, they found out clonidine is comparatively safer, but moxonidine is not safer. So that's what, clonidine, there's no use to use clonidine in a pregnancy or women. But still, for theory purpose, clonidine is better than moxonidine. Moxonidine cannot be used. Clonidine, moxonidine can travel through placental barrier. Okay, can IV nitroprusside be used in hypertensive crisis in pregnancy?
No.
I don't think so.
We don't.
No.
Because
Again, nitroprusside is not used because it can cause cyanide poisoning overall, for the both mother and fetus. And nitroprusside, is a both arterial and venous dilator. So it'll be a problem compared to nitroglycerin, which is venous dilator. This is both and any nitroprusside, especially it can cause cerebral hypoperfusion. So any cerebral involvement, normally we don't use it. Are postmenopausal women on HRT more prone to hypertension per se? Postmenopausal women on HRT.
that can be, that is true, because
No specific answer to that, sir, but generally these hormones can induce hypertension.
But Prabhakar, to my surprise, I saw HRT doesn't increase blood pressure in postmenopausal women. That's what I read in some of the article.
But
So
Geeta showed in her slide,
Yeah.
ART is one of the,
Yeah, I know, but see, HRT theoretically in postmenopausal women can increase hypertension. But I read in one of the article, it need not produce hypertension in a postmenopausal woman HRT. I'll ask you one tricky question, Prabhakar. You say estrogen is very good. When you give contraceptive pill, which has got estrogen, why it increases blood pressure?
Sir, I don't use contraceptive pills.
it is
Okay.
possibly synthetic. Yes, that synthetic and the natural is little different.
And also,
This
one
is
more reason, Prabhakar, in cumulative effect of estradiol and compared to synthetic and natural.
synthetic and the natural.
Yeah, and also cumulative effect. When you do chronic contraceptive, it increases blood pressure. So, I mean, this is a paradox. Estrogen is supposed to be good, but when you give estrogen as a tablet, it produces hypertension, especially chronic.
But estrogen in
What is
physiological doses, which is treated by the, it is a hormone which is there in the body. In physiological doses, it is good.
Yes.
But if you're consuming it for, contraception, definitely the concentration will rise in the blood. And that it will have a steroidal effect.
Yeah.
Same as the steroids increase the blood pressure.
And especially ethyl estradiol present in the contraceptive pill can produce.
Still it is estradiol,
So what is the current status of hormone replacement? Because after the HERS trial and HERS1 and HERS2, initially we said don't use postmenopausal.
Rebecca, if I have to tell
hormone
you,
replacement.
because there is one very good Danish study, Denmark study. Basically, the timing of use is important. Don't use, after the menopause or this is around perimenopausal, where you think,
menopause you can use.
Yeah. There is a definite. It's quite a long study. I think 8 to 10 years follow up, and that all Denmark studies are highly respected. That, and this is a Danish study. Good large number of patients. So around perimenopausal, if you think you need like hot flushes and very symptomatic, or for the vaginal secretions, all those reason when we need hormone, I think it is justified. And there is a positive benefit of this hormone in the years to come. But already menopause is occurred, now we are giving, it's not. So it's a timing is what has been mentioned. I don't have that particular. I may probably put it in the forum.
No, I agree. I also read that. It is good like that in perimenopausal area. And Yogesh is asking, is hypertension common in adult mental institutions for women? I don't know. Adult mental institution for women.
I just saw the question because it's difficult to answer because
No. See, what he means is when women have sort of mental worries, confusions, is the hypertension common?
That all because we put them, make them as a second-grade citizen. That's all in us,
Yeah.
We always say, females, we don't consider as a prime.
Geeta, one question from Poonam. Why urine PCT? PCR. Why urine PCR?
There is a proteinuria.
As one of the investigations to find out if there is any proteinuria, sir.
Proteinuria.
Because in order to determine what would be the better choice of antihypertensive drug.
Proteinuria.
that-
It is not PCR. No, proteinuria.
Yeah.
Proteinuria.
Yeah, it came into
Proteinuria.
PCR.
Okay,
It is
maybe
protein creatinine ratio.
creatine ratio.
Proteinuria,
Creatine ratio.
Creatinine ratio.
Yeah, that actually albumin creatine ratio, ACR, we call it as ACR.
ACR. Okay.
ACR.
No,
Because,
ACR is more specific nowadays.
yeah,
Most of the centers don't have ACR, so they do PCR.
So
Yeah,
PCR,
yeah.
yes, exactly.
yeah. So that is, specifically for that, yeah.
I think, there are many questions also. The last question I'll ask. Comments on bendroploside. Butani.
Bendroprostazide
Yes.
is only available in the UK, I think, that's why, NICE guideline chairman always talk about this medication. It is like a thiazide diuretic. I don't think we have got much experience of using this. Yeah. But now even Brian William is moving to chlorthalidone because last when he talked, he's going into chlorthalidone and indapamide. He's very thrilled after meeting us in India, availability of chlorthalidone very easily, 6.25, indapamide small dose. So that bendo, this thing is, only in UK, if I remember, I don't know, Prabhakar, you about this, bendroprostazide?
No, sir, I've not used it, but apparently only thing I remember about that is it produces more of hyperuricemia compared to the other drugs. I think that is the only point about bendrofluorothiazide.
But
And,
only thing, sir, here I want to just make a mention here. Recently, we had almost a physical meet. Our ESC earlier president, I forget his name. Our in fact,
Roberto Ferrari?
No, not Roberto Ferrari. I'm very fond of him. He's the only guy who is beta blocker boss. He always talk about the beta blocker. I forget his name. But now thiazide diuretic is also coming back. What we are thinking, the chlorthalidone is that now thiazide diuretic is also coming back, sir. Like there are 3 studies which are going on, which are large study, in different places. Europe, I think is going in Holland, and then one in the USA, and maybe some other country, and a large number, And now they are saying hydrochlorothiazide we should not be disregarding, So hydrochlorothiazide also is supposed to be better because this was organized by one of the very popular our pharma who have got both chlorthalidone and hydrochlorothiazide. So hydrochlorothiazide also should not be neglected because we are thinking about all metabolic problem, then it's hyperglycemia, all those things are more with that. Hyperuricemia is not necessarily, even thiazide also is as good as chlorthalidone.
In fact, the International Society of Hypertension guidelines also says if a patient is controlled well with the hydrochlorothiazide, don't change.
Yeah, exactly.
That should not be changed. And what you're saying is, I heard about that meeting also, wherein they clearly said that thiazides are not that bad.
Yeah.
You're talking about hydrochlorothiazide.
Yeah.
When the Hyvet study came and indapamide came, indapamide is an exclusively European molecule.
Correct.
So the Americans asked, what is indapamide?
Correct.
That's how it started actually when the Hyvet study came. So these are all area specific ones, but hydrochlorothiazide need not be discredited as much. But as of now, chlorthalidone is good.
Mansia, Dr. Mansia, he is one of the
Mansia is not from, he's from Italy. No, it is.
Italy, Europe. That's what I'm saying, sir. He's from Italy.
Yeah.
He is one. He was one of the speaker. I was moderating the session, and he and one guy from USA, and there are a lot of data he gave that hydrochlorothiazide don't disregard because at least I used to tell all the meeting last 2-3 years. Now for us only chlorthalidone and indapamide. So after that meet, now we can't just say that, possibly.
Okay, last 2 questions. There are 20 questions more, but still, Garima, my friend from Madhya Pradesh, is in hyperthyroid female on propranolol when gets pregnant. Which drug should we change to? A patient, female hyperthyroidism with pregnancy.
Yeah.
She's on propranolol. What drug you have to change? Definitely, labetalol can be given because it's after all a beta blocker, and when she's got pregnancy with hypertension, there is no harm, and propranolol can be substituted with labetalol. I mean, this is what I think. What is your take on?
I think reasonable. I also would say, but probably if propranolol is controlled and any beta blocker is okay. Now, whatever non-selective beta blocker should not make a gross change during pregnancy. So both alpha and beta blocker action, what we see in labetalol, here also, like a non-selective alpha and beta. So I think it is okay. No harm in continuing that also, I would say.
I also agree, sir. Definitely, because if propranolol is not bad.
Yeah,
Though
it becomes
labetalol is
better.
a good choice,
Not contraindicated in
not
pregnancy.
contraindicated.
But normally we always say LNM, labetalol, nifedipine, and methyl dopa. For a choice for pregnancy, LNM, I'll say labetalol, nifedipine, and methyl dopa. So beta blockers also,
Beta blocker should be
propranolol
okay.
can be given. Okay, last question. 30 weeks pregnant eclampsia woman in critical care not responding to IV labetalol. What is the next step, sir? They can give IV hydrolysine. If IV labetalol is not there, IV hydrolysine can be given also.
No, if it is, like 30 weeks, if the growth is okay, probably the only way is induction of this. Yeah. And the other thing, magnesium sulfate, because that also would probably reduce the pressure as well as probably the whatever conversions, other thing. I would say
Because
yeah,
eclampsia means delivery is good.
Yeah,
If it is pre-eclampsia,
yeah.
34 weeks, we'll
Yeah.
wait up to 34
Yeah,
to
because
37
it's
weeks.
eclampsia, no?
Yeah.
It's
Yeah,
eclampsia.
that's what.
Yeah.
So another drug which does not respond to labetalol, we always try IV hydrolysine, which is another drug which can be used in pregnancy, hypertensive pregnancy emergencies. I think there are so many questions. I leave it like this. Now I'll come to one by one. Let us start with Meenakshi. Your final comment, Meenakshi.
So final comment is that while we are managing the patients, two groups, one in the discussion what came about the pregnancy and other was the post-menopausal women. There is difference in the drug prescription and the the approach to the patient of hypertension, females with hypertension. And I'll talk more about the post-menopausal because I'm more working with them. So the drugs which have already been taught by Dr. Geeta, we should consider those and take care of their cardiovascular risk profile as well as check on these things that the drugs which we're using, especially the diuretics in elderly people, because they usually, especially the males who have already the lower urinary tract symptoms and they have incontinence and urgency. So when we are using diuretics in them, we have to be a bit cautious about using diuretics because after using diuretics, they have the increase in frequency of urine and they have a tendency to fall. So that is one caution which when we are dealing with hypertension in elderly males, that is one thing we should remember.
Yeah, and also because Rishikesh, you are the most of the time cold weather. Is there any cold weather has a play in the hypertension, especially women?
Yes, not exactly. I didn't particularly look for women, but yes, temperature variation does have an effect on the hypertension because I'll just send you the article which I'm preparing these days.
Yeah.
So that is I have read it. That temperature it is a maximum effect is on because of the temperature on the blood pressure variability. So that is because the pollution increases during the winter season. So it has the maximum effect during the winter season.
Yeah, the seasonal variation is always, you must reduce or increase according to the seasonal variation. In fact,
the seasonal variation actually is about summer and winter. Summer, there is dehydration because of sweating. So you actually, in the elderly, you have to reduce the dose of antihypertensive drugs.
Yes, especially in the rainy seasons because they perspire a lot, and even I don't prescribe them the salt restriction, especially at those times. They have a quite lot of dyselectrolemias during that period, during the summer seasons.
I read on an article, Enigma study, UK Enigma study, what they say, the people with 18 to 48 years male, the phenotype is more of a cardiac type, where the vascular resistance is normal or low. Whereas in a female, 18 to 49, the phenotype is most of a vascular type, where the vascular resistance is more. This is a study by Enigma study, UK Enigma study, where there are 3,500 people they have read and then said different phenotype in adult, this 18 to 49 male and 18 to 49 female. One is cardiac type, other is vascular type. This is just for completion's sake. Okay, come, Salanand, your final comment.
No, I learned so many things. It's nice to hear Geeta, and it's an honor to be with you. That's the only comment. Medical, we already.
Thank you so much. Thank you so much. And I must thank both of you voluntarily asking and then coming. Really great, academicians you too.
And we are not bothered. It is 11 o'clock. Still going.
Yeah, but still, there are. You can see there are 130 people still listening.
Yeah.
It's not. It is not new. We always have that way. Okay, Prabha, your final comment, Prabha.
I have only one word of caution. Dr. Shetty spoke beautifully and can summarize the pregnancy part. the postmenopausal, she said, but I think what we neglect is the premenopausal woman, the woman in the childbearing age group. See, those people, they start hypertension by the 3rd decade. Once hypertension starts, even the pre-hypertension or the stage borderline hypertension, 130 to 140, 80 to 90, that blood pressure is found to be detrimental. What we tend to do is to delay treatment for them. That is one subgroup we have to focus on and treat a lot more. I think that should be a very important message that we give, because we have to probably redefine hypertension in women. That is coming in the future. But I think at that age group, we should focus a lot more, diagnose it, at least institute lifestyle modification the moment you see that. Even
Yeah,
if not drugs.
that's why my introductory slides, you could have seen, I said people think only 5th cycle or postmenopausal BP goes up. It starts in the 3rd decade itself. That's what I mentioned. Also, the BMI has got a very big role, impact in women. The BMI, if it is more in men compared to women, women have more problems. So that's why, you know, lifestyle modification, they don't undertake. As Geeta said, if you tell your women, you do exercise, they say whole day I'm working, they don't take care. And most of the women with hypertension are obese. So I think obesity again adds to the problem. And obesity also, you know, produces a lot of drug changes and things like that. Now, Meenakshi has finished. Now, Sangram, are you there, Sangram? Yeah,
sir.
You are quite.
Yeah, as usual, it was a wonderful. My concern, my takeaways are basically, I still believe in history taking, a good clinical examination, like we call it as a peripheral circulatory tour. Before exam, coming to a proper cardia, do peripheral vascular examination, see for the basic things, then classify the hypertension properly, exclude all secondary causes. Reassurance of the patient is very important. Hormonal therapy is quite significant and should be a patient-centric approach for the treatment of hypertension in women. Titrate the drugs accordingly. Selection of the drug is very important. Thank you.
Yeah, because history taking is very important to rule out secondary hypertension. So long we'll think only hypertension. In women, secondary hypertension also over the primary hypertension they may have. So fibromuscular dysplasia, if you do the stenting, you know, it will definitely, you know, be good like that, you know, history taking is important. Now, Geeta, Geeta, your final comment.
My final comment is, sir, I think as I just started the presentation, we have to go back to the basics. Somewhere we have lost the basics. So we find that there is a significant increase in many kinds of diseases. Like it also includes malignancies and heavy number of PCOS. I still remember that as a 3rd year student or a final year student, PCOS was just one single line mentioned in the gynecology textbook. And we used to read about clomiphene citrate, and that was meant for the MCQ preparation. But now we have started to see it in reality. And getting back to basics, what I mean is the physical activity. Somewhere I think we have to stress upon this aspect as part of curriculum, because nature has designed each of her components, whether it's the flora or fauna, the animal kingdom, to have its set of activities appropriate for the age. We have gone beyond what is appropriate. And I think it is having a huge take on the health of a whole population. And hypertension is just one at the end of the spectrum. Thank you, sir.
Yeah, but yeah, PCOS got so many other problems like dyslipidemia, obesity, diabetes, hypertension, everything. So we always, when somebody comes to PCOS, we must be very careful. Fine, I think we had overall a very good discussion and debates on hypertension, women and hypertension. I am really fully happy and satisfied that, you know, we have brought so many new points and so many people have learned new points about hypertension, especially women. So they must take care of the women because like the famous cardiologist said, don't have pick me approach. You must have a full approach because cardiovascular problem is more in women and you must submit them for regular checkup and regular follow-up is necessary. So thank you once again, Prabhagar and Sadan Sethi for wonderful participation. Of course, Meenakshi there. Thank you, Meenakshi there. Sometimes overworking, sleeps in the evening, so that's why she couldn't come for my World Medical Conference. So I forgot to remind you, Meenakshi. So I told the Mega to remind you today so that you will join us. Sangram, thank you, Sangram. Thank you, Geeta.
Thank you, sir.
Excellent.
Thank you.
I must say, Muruganathan, you got an excellent secretary. He's also like you only. So
Yeah,
much.
yeah, yeah. I train her, I groom her, that way.
Yeah,
She's-
yeah. She also got magnet like you, because
Yes.
suddenly,
Thank you so much, sir.
Yeah,
Okay,
she's from
okay.
Delhi. She's working from Delhi for us.
Good, good.
Anyway,
Yeah.
thanks a
Okay,
lot.
bye.
And all the participants for the last 5 webinars, your gifts or prizes will come to you, and participation certificate and the medical council accreditation certificates also will come. So we'll stay in touch. We'll definitely have one more masterclass webinar series. We'll discuss with Sadanand and Prabhagar, and we'll roll out some more new topics. Of course, pregnancy hypertension itself can be a new topic, which I think they have got a lot of things to learn and a lot of things to do and study. Okay, Geeta, thank you. Thank you, Sangaran.
Thank
Thank
you
you,
very
Megha.
much.
Thank you, sir.
Thank you so much, sir.
Thank you.
Thank you,
Thank you,
everyone.
Thank you, sir. Thank you.
Thank you, thank you, sir. Thank
Geeta, very nice. Thank you.
you. Yeah.
Thank you so much.
Thank you. Good night, one and all. Thank you.
Good night,
Okay,
good
Good
night.
night.
It's 11:05, Geeta. Okay, Megha, everything went on well.
Yes, sir.
You are even, a lot of questions, lot of discussions.
Yes, yes. Remains.
yeah.
So many
Okay.
questions.
You
Right,
also
sir.
added a lot of points, no new points we added.
Yeah,
Okay. Thank
definitely.
you so much. Thank you.
Thank you, sir. Good night.